So thank you for inviting me here today to talk about the in situ simulation programme that we run here in City and Hackney within primary care. And I know that was a question earlier. You know, how do we take simulation training from secondary care into primary care? And hopefully this brief overview will maybe give you some ideas on how you can do that. So I don't have any conflicts of interest, and I just want to say obviously a big thank you to Valerie Dimmick, who on the simulation training team here, who helped set this team up, and my colleague who helped with the presentation as well. So who are ACEs? So I work for an acute cardio-respiratory enhanced and responsive service. We work across both the primary and secondary care interface. We treat patients across the whole pathway from diagnosis to end of life. We're made up of physiotherapists, nurses, psychologists, we have rehab assistants, administrator, and we have many students, nurses, physios and medical students as well. And we have a nurse consultant lead. So why was it important to try and develop a primary care simulation training programme? Well, primary care is very isolating. At times, clinicians can be by themselves making critical decisions in complex situations. It's quite difficult, even for the most experienced clinician, and you know, our patients can be very sick. They're often potentially needing an admission, or at the end of their life, and our decisions can be critical. So it's also the fear of the unknown. The environments we go into are unknown. Many of our patients are vulnerable, they live alone, and we have a large non-English speaking population in City and Hackney, which can present challenges at times, especially when you're going in to a patient who has called up for review when they're very sick. So even the most experienced clinician often asks, what can I do? You can't always get to talk to a colleague. Help can be minutes away rather than seconds. And the environment can be very challenging. This is not the everyday environment we go into, but I have been into houses like this. So before you can even treat the patient, you have to get access to that patient. There's clutter, there's access just getting into the building sometimes. There are pets, wanted and unwanted. And we have family members as well. So the environment can be a challenge. Simulation centres are fantastic, and I've done a lot of simulation training within our sim centre, but it isn't a real life environment for the primary care clinician, and therefore the events don't occur in the same time, and equipment is very different and the support available. So I noticed there was a gap. We're a 7-day-a-week, 24-hour-a-day service. Training time is rare and precious, and it's really difficult to do training as a team, because you can't take a whole day out as a team when you have a service to run. Money is tight as well, we know that. Budgets are being reduced all the time for training. And the other thing was, when I looked, there was very little evidence to support simulation training in primary care. There was no examples of what other services were doing or how they were being run. So I thought there was a gap to fill. So myself and with the help of Val, we came up with a low-tech community training programme that met the needs of the MDT, but also that was achievable within the time we had. The sessions are an hour and a half long, and they fit into our team meeting. We run them once a month, and they are all based on real-life clinical scenarios where it was felt learning could be made, or even the most simple scenario, just to ensure that everyone felt confident and competency levels were met. Here are some of the scenarios or the clinicians doing the scenarios. Every 4th or 5th session, we do a scenario writing day or session to help support the members of the team with writing scenarios. Through this programme, which was set up in 2015, we've increased the number of trainers. All the team are involved in the scenarios, and it's helped communication within the team. I think we understand each other better and the roles in which we take, and we've been able to share skills and learning. Soft skills have improved, and we've identified the human factors that we all talk about within simulation training a lot. So here are some of the examples of the sessions that we've run. They've been from very complex disengaged patients, post-discharge. We've had patients with safeguarding issues, suicidal patient scenarios, acutely unwell patients at home that didn't want to be admitted, things that happen every day in primary care that you go to and it's unfamiliar and you're not sure how to deal with it and you don't know, you sometimes don't know what you're going into. I think we've surprised potentially our simulation colleagues with how complex some of the scenarios and situations that we work in primary care are and how isolated we can be. And I think that's important when we're looking at multi-professional and primary care learning, is how can we take simulation training from secondary care into primary care and make it achievable and realistic to the situations colleagues go into. At the end of every session we complete an evaluation tool as well. And there have been many benefits and challenges to the programme that we've run. It's cost effective, we've had minimal equipment needed, it's been very quick to set up, and we found it really doesn't cause any disruption to our service. We can still monitor our or we can still manage our on-call phone during the sessions. It's given the whole team access to training, and with our nurses especially, who are undergoing revalidation, this is something they can put towards that as evidence of their learning. It's involved the whole team are involved, and we're a team of now nearly 30 people, and the whole team can receive the training in one time in our environment. And we observe it live. We don't need a lot of technology, we don't film it, sometimes we take photos, but we don't film it. So it's really quick and easy to do. But there were challenges, especially the engagement of staff. People were very, I suppose, unconfident initially and wanting to share their practice and their skills. So therefore engagement with debrief at times initially was limited. Getting participants, people wanting to be involved in the scenarios, especially when they're taking the role of the staff member, has been a challenge, but something we've overcome. It is time limited, and we would love to run more scenarios. We are limited often to one scenario, and once a month. There is so much more learning we could do. And sometimes lack of equipment is an issue, especially when you're trying to create a cluttered environment or a patient's home environment. But we have identified and improved the quality of the service we've run through the identification of latent errors. We found that within our rehab groups, for example, there was a need for glucose blood monitoring kits, something that we didn't have. We've created a suicidal risk pathway for staff to access, not for staff, but for staff to access. Because we found on a Friday afternoon, what do you do if you call a patient or you go and see a patient and they're saying to you that they have suicidal ideations? What does that staff member then do? Who do they reach out to for help? And we've also identified the need for correct medication at home. We treat patients for COPD exacerbations, and if they phone you in the middle of the night and they've got no rescue medication, you've got to make a call to an out-of-hours service, or you are sending that patient into A&E. So, it's a way of avoiding admissions. And for clear leadership, especially from the junior members of the team when there's been an emergency situation. You might have a patient collapsing in a rehabilitation group. It might be a junior member of staff who's leading that group. What happens? How do they react? And it's quite interesting that even sometimes the most senior members sit back and wait for someone to take the lead. So the feedback has been really positive. 100% of the staff have said training has worked. They feel very engaged in the training. It's enhanced their practice. All the staff find it really enjoyable. They say it's fun. We always get the comments, can we do more? We need more time. And we were very lucky to receive an award for the programme earlier this year from UCLP. And there's just some of the comments that the staff have made. But it's also the hidden things, the surprises that you don't know. And I think for us, the biggest hidden surprise from our simulation was the talent from the staff and the number of staff members who have got hidden acting skills and who do fully immerse themselves in this training. Imagination is key, I think, and having someone who's passionate to drive the programme and having someone to support that passion when you don't know how to implement your idea. And I was very lucky to have that through the Simulation Training Centre here. But I have to say, what's next is we do need some way of measuring it. It's very difficult to measure the effectiveness of this training programme apart through the identification of latent errors. Therefore, more research is needed for simulation training in primary care. The evidence still is very biased towards secondary care and critical care medicine from what I found. And I'd love to integrate this programme further into our GP colleagues or to the other community teams. But again, time is precious, and that has been a barrier. So in conclusion, sim training does work in primary care. You need to be imaginative and passionate. You can do it with minimal disruption. It's easy and it's cost effective. Challenges do exist, but as I said, imagination helps to overcome them. And it is, to our staff, it's been 100% beneficial to their learning and their needs. So it's a very brief overview. Thank you very much.